Welcome to FFRF's Ask an Atheist. I am Kristina, Daleiden, Programs Manager here at FFRF. This week on Ask an Atheist, we're looking at the widespread increase in power of the Catholic religion over healthcare in the U.S., even for folks who aren't Catholic. If you have any questions, as always during today's show, you can post them on the Facebook comments or send an email to askanatheist@ffrf.org. Today, I am joined by one of our newest members of the FFRF family, Joseph McDonald, who is the Patrick O'Reilly Legal Fellow. Welcome, Joseph.
It's good to be here. Thank you.
Absolutely. So, Joseph, you've worn a lot of hats in your career before you became a lawyer with an interest in the Establishment Clause. Tell us a little bit about your background.
Yeah, so my background in healthcare is quite extensive. When I was in undergrad, so I've done all my degrees at the University of Wisconsin-Madison. So during undergrad, I was a researcher. I was looking at cancer health disparities with the Carbone Cancer Center, and I was a statistician. So that's kind of where my initial work in public health came from, as well as getting my degree in global health. When I was a teacher and a school principal, I was also the developer for the pre-diabetes prevention program for the YMCA in Winona, Minnesota, and in La Crosse, Wisconsin. So I would help people, clients, get access to insurance providers and teach them how to live a healthy life, exercise, daily tips and tricks to lose weight and push off the onset of diabetes. And then when I did my master's in public health, I was a health policy analyst with the Population Health Institute and the evidence-based health policy program. So in that space, I was really looking at policies around the state and around the country, and doing a significant amount of research, as well as working with the legislature on informing them how to understand the health metrics in their districts, and educate them on how to read some of these health metrics as well. And then in law school, like I said, it's extensive. In law school, I was a researcher in one of the journals where I examined the relationship between abortion jurisprudence and current abortion laws. And their relationship with some of the healthcare disparities that we're seeing in abortion care, and some of the misunderstandings, as well as examining how medical legal partnerships can engage and reduce those disparities. So a mouthful, but I'm happy to be here and happy to continue my work in healthcare.
Well, we're delighted to have you,
Yeah.
and you bring a lot of incredible experience. We're looking forward to using that expertise and moving forward.
Yeah.
So today, something that FFRF has been experimenting with in the recent COVID times is a new program called Coffee and Conversation. It's a Zoom webinar where FFRF members can interact directly with attorneys and discuss specific topics. Our first one back in April featured our Director of Strategic Response, Andrew Seidel, talking about Christian nationalism and its influence in America. Now, this past month, Joseph and Associate Counsel Sam Grover discussed the history and expansion of Catholic hospitals and how secular patients can navigate Catholic ethical religious directives. Coffee and Conversation is available live only to current FFRF members. So if you'd like to join in on one of the webinars, simply log into your membership account and sign up for FFRF's events and appearances email. You'll receive email invitations, including the registration for Zoom, as well as notifications about other upcoming events and appearances. Now, we are going to play back the first part of the most recent program with Sam and Joseph, which runs about 40 minutes. After that, Joseph will be taking your questions on this important subject. So again, you can leave your questions in the comments section or send us an email. Bruce, you want to go to the video, and we'll be back with your questions in a bit.
I'm Sam Grover. I'm litigation counsel for FFRF. I've been with the organization since 2013, and I'm happy to be discussing this topic today. It's near and dear to my heart. I've pursued a career in free thought and the things that go into the Establishment Clause and Free Exercise Clause. But I also have a pretty strong interest in healthcare and sort of the rights and access issues that go into that. And joining me today, very excited to be joined by Joseph McDonald, who is our esteemed Patrick O'Reilly Legal Fellow. He's been with FFRF for about 9 months now. And Joseph received his law degree from the University of Wisconsin. And equally relevant for this talk, he also has a master's of public health. So his career, he's had a fascinating career that has crossed through the public health field over and over again. So in addition to having been a teacher and a school district administrator, he's also been a data analyst and researcher for the Carbone Cancer Center, health policy analyst, and a researcher and writer on the relationships between abortion-related health disparities and medical legal partnerships. So in short, he's just the sort of person that you'd want to talk to over coffee about all things at the intersection of free thought, healthcare, and the law. Joseph, go ahead and say hello.
Hey, everybody. I'm really excited to be here. I'm really excited to talk. This is because I onboarded, as Sam said, 9 months ago, during the pandemic. I haven't had a close relationship with the members, and this is the closest I feel to everyone here. So thank you for your membership. Thank you for the opportunity to speak. And I am very excited to finally have coffee. I waited a long time to have my first cup of coffee, a little longer than I normally do. So I'm very excited.
Oh, so that's interesting, actually. I wasn't sure. I wasn't sure like exactly what the premise of this program was. Obviously, first and foremost, it's about getting to communicate with our members. And I can see here on the participant list a lot of familiar names. So hello, everyone. Thank you for joining us. I wasn't sure if the goal here was to sort of watch us wake up on the call, right? Like to have our first sips of coffee on the Zoom call or not. So I'm actually on my second cup. And so I might be cheating. I'm not sure if that's in the spirit of the program.
Well, I authentically have my first cup of coffee. It's been a little longer than I wanted to wait. So if I fumble over anything, it's because third, I'm jealous.
Yeah, so today we are talking patients' rights. So all the things that go into your rights or the rights of your loved ones as patients in the healthcare system, and sort of what the pitfalls are when those rights clash with quote unquote religious freedom as it has been broadly defined by the current conservative activist Supreme Court. So Joseph, you are our expert. I'm just here so you don't look lonely on screen, I think. So my understanding is we're going to start a little bit with you just sort of giving us a background on how it came to be that religion and healthcare have become so interwoven in this country.
Mm-hmm.
Or I guess, or maybe that's always been the case. Why don't you take over?
Yeah, so I think the relationship between medicine and religion has been a fascinating one, and it's a global story. So really, we're looking at the early onset or the early records come from the 5th and 6th century, but where early monasteries or early Catholic monasteries were hotbeds for not necessarily healthcare and medicine, because those are really contemporary terms, but they were really the homes for social good, right? If there was someone who needed to, who was homeless, I guess, quote unquote, or didn't have food, was dying, starving, had illness, they could go to the monasteries. But this is 5th and 6th century, so obviously our context of medicine really didn't develop yet. Really, the first big sign of medicine and this like hospital idea came from the Black Plague. So thousands of people would gather into these spaces as quarantine or self-containment, either because they already were infected, or they were quarantining away from their loved ones who and they hadn't had symptoms yet. And so this is thousands of people pulling together. This is 10th, 11th century. early hospitalization, really, through these quarantining efforts. And public health didn't become a thing until John Snow famously found the tracked tuberculosis to a well, which is in London. It's very interesting. It's not very exciting to go there. I've been there twice. It's not super exciting, but the story is interesting. And then as we go through a little further, you get these lore of war and medicine. So during the 15th century, you have Florence Nightingale and her crusade to provide like early nursing care, which is really the fundamental lore behind the American nursing system and actually international nursing systems. But the church really dominated the space though. Take for instance, Leonardo da Vinci. This is a good bit of dinner time talk, I guess, or if you're ever at a cocktail party, is an interesting point. He was one of the early authors, you could say, or early illustrators of the human anatomy. And he did this by doing these late night dissections, but the Catholic Church did not, they frowned upon dissections. So even though there was scientific good and artistic good to come out of that, his seminal works in dissection were published posthumously because the Catholic Church frowned upon it. Now, they later on supported it and said, "Oh, we always, supported his works," but that was not the case.
Yeah.
And this is 15th century. I mean, this is 1489 that these works get published, and so you can't even draw a picture of a body, let alone do the actual work.
Right. So to sum up the early state of things here, the church dominates the healthcare space to the extent that healthcare is a thing, or I guess it's just care at that point, right?
It's just yeah.
And they're sort of resisting exploration and progress even.
Yeah, I mean, this is really just this is before we even had this idea of like the four biles, if you know what that is. Because once we started to so after this point, I'll come back to the four biles in a second, but we get to this point where medicine really starts to develop, right, throughout the 17th, 18th, and 19th centuries. So like Leeuwenhoek, first, I mean, you think of how early this is, 1659, 1671, develops or first makes the discovery that we have red blood cells, right? We're moving away from those four biles. So it's like yellow, black, red, and I think it was like orange or something like that. You have the four biles, and they thought that, oh, you have snot coming out of your nose? That's like dishonesty leaving the body. Like, no, that doesn't make any sense. And so you just think about the human record as we make these scientific discoveries in medicine, we move away from the church, right? You don't have to pray to have your body understood anymore. We understand it from a scientific point. So yeah, I mean, I think that's a
so then so we have the sort of secularization and of medicine as it becomes more science-based over time. Is that sort of what you're saying?
Yeah, absolutely. And again, it's a story that gets conflated with wartime too, because oftentimes the military, like the soldiers, would all get gathered into these spaces, and because they had injuries, it really became a hotbed for, I guess, quote unquote, a hotbed for medical discovery and medical innovation, because you had so many patients that needed care, and there was such egregious amounts of care, right? So throughout the 16th and 17th, or the 17th and 18th century, Leeuwenhoek discovers blood. We discovered that there are bacteria. The first successful appendectomy is performed. And then you see this huge boom of scientific discoveries, medical discoveries in the 19th century. You have the vaccine for cholera. You have the germ theory becomes developed. You have vaccines for the bubonic plague. You have all these things really developing. And they're really moving away from, oh, I need to pray and I need to have church control over my body. And now you have really science and medicine being the foothold in medicine.
And heroin, right?
And of course, heroin and a lot of medical cocaine. That was also a thing.
Yeah, so we're not saying it was immediately great or immediately perfect by any stretch, and this is happening. If we switch to the United States now, are we seeing the same pattern here as well?
Yes, yes, we are. So you still have the conflation of social care with healthcare, right?
Mhm.
There's a really great example of that with the Jane Addams homes in Chicago, which is where I'm from. And there are whole city blocks that provided social care. But you still see the medicalization of healthcare advance and move away from these primarily Catholic, but generally religious hospitals and healthcare providers. At this point, we're talking about the church, right? Healthcare is no longer being provided by the church. Um, as science develops and as medical innovations develop. Um, but yeah, it's the same story that happens in the United States, all the way up until early 20th, mid 20th century.
Okay, well, yeah, I was gonna say, like, this sounds great. We're leaving the science to the scientists, and the prayer in the church. So why are we having this uh, Zoom webinar, right? Like, what's the problem here?
Yeah.
When do we see that? When do we see them reconverge?
Yeah, so we really see it post World War II is really the early founding of it. Pretty much as the United States is one of the few countries after the war that doesn't develop universal healthcare. You see, after the world wars, other countries develop um, systems of national healthcare. You see it in the UK with the NHS. You see it in Germany. There's a very specific system in Germany. You see it in Canada. United States starts that process and then we scale it back. And then it never gets implemented until we have efforts really being founded in the Affordable Healthcare Act. But what it does do is it creates governmental programs that financially reimburse healthcare providers. And then you see the development of the appropriation of funds to Catholic churches. You also see the boom of the healthcare market as a private entity, as a private market. And so really it's an economic story that happens throughout this whole period, a tax story, an economic story. And then throughout the 80s, you see, and this is what you can see today, is this large, vast network of healthcare systems, these healthcare networks. It's no longer, oh yeah, I go to Dr. Stephen Joe Heimerschmidt down the road. He's my family doctor. We don't see that anymore. It's really these healthcare systems and these networks. And as we have seen it today, the largest growing healthcare network and healthcare systems are Catholic churches and Catholic hospitals.
Yeah.
Since 2011, they've increased by 20%. The number of beds have increased. Some states are dominated by Catholic hospitals. And the issue with that is that they are not solely driven by even an economic story. They're not solely driven by a public good or healthcare consumer good. They're driven by these Catholic directives, which is a huge issue, and they're unregulated.
Yeah, so we'll get to the directives in a minute. So I just, to summarize in my own personal words, basically you're saying that the church renewed its interest in healthcare once there was money in it. That doesn't sound right to me. That can't possibly be it.
I mean, it is a greedy story. It is part of the story. It's certainly not the entire story. I mean, you know, why do so many Republicans or why do so many, right-wing conservative politicians object that the Affordable Care Act? I don't know. Certainly there's an economic story, but there's also more to it. There's more human side to it. So why do we
No
see
doubt.
the development and the expansion of Catholic hospitals? It's a multi-layered, multifaceted story. Certainly economics and the tax code is part of it, but there's so many other sociological components to this as well.
Okay, so before we get into what we see as the problems of the sort of the it's we're probably going to keep saying Catholic takeover of the healthcare system because it is predominantly a Catholic takeover. There are some, a few other religiously run hospitals out there. But in terms of like raw numbers, can you take us through like how big a share of healthcare are we talking about?
Yeah, so that's a great question. So this is where the public health side of my background really comes into play, because healthcare is so complex, as our wonderful former president once said, who knew it was so complicated or so complex. It is, and we measure it in so many different ways. In terms of the expansion of Catholic hospitals, there are multiple ways to look at the measure. So one is just pure market share, right? That's, when I say market share, I mean it's an analysis of expenditure. Basically, it's a money analysis. How much money goes through these Catholic hospitals? And in some states, the 70% of every hospital dollar goes through a Catholic hospital. When you look at and start to put that into perspective, some counties only have Catholic hospitals available in them. And therefore, every dollar of healthcare, whether it's state funded, federal funded, or consumer dollars, insurance reimbursements, it all goes through the Catholic hospital. And by effect, through the Catholic Church. In the United States, it looks very different. In Wisconsin, where we are headquartered here, some hospitals, some counties are 100% market share. Some counties in Wisconsin are dominated by Catholic hospitals by a market share of more than 70%, nearly 100%, because of the monopoly that they have in those counties. Throughout the United States, you see an averaging of about 50%, 50% market share.
Wow.
Another way to measure that, though, I think is, and this is important, is in acute care hospital beds. Let me pause and just ask, do you have any questions about the market share, like part of that? I know that can be complicated.
No, I think I get that. Like so whenever you're talking about, healthcare being a multi-billion-dollar industry in the United States, you're saying, 50 to 70 cents on the dollar or more in some areas of the country are going through Catholic-run hospital systems.
Yes, absolutely. Yeah. Absolutely, that's what I'm saying.
That's astounding to me. Why did they need all of these COVID bailouts when they've got access to that much money?
For organizations that don't pay taxes anyway, it is a great question. It's a really good question.
We didn't really touch on that in terms of the economics of it. Right. So when a church like the Catholic Church starts to go into the field of healthcare, right, something where it's competing against organizations that aren't religiously affiliated, there are economic advantages for the church when competing for a share of that market, right?
Yes, there absolutely are. So most hospitals are nonprofit hospitals. They're categorized not under 501c3 as nonprofit institutions, but 501c4, which is still a nonprofit status, but it's slightly different. And what happens is that so here's a good example. When you're a 501c4 or 501c3, you have to file what's called a 990. It's your tax form that requires you to state what the highest earnings are and what the bonuses are for your employees.
Oh yeah, FFRF is very familiar with the 990. We file them every year, and we've had ongoing legal battles now over the fact that we as a nonprofit are required to do that as a secular nonprofit, while religious nonprofits, i.e. churches, do not have to fill out that form.
Nor do those religiously affiliated hospitals. And that's
wild.
A huge issue. That's a huge issue. I mean, you look at what some of the bonuses are for some of the secular hospitals, you can see that there's a clear skewing of expenditures, right? For example, I believe if you look at the 990 for Freighter, which is it's the largest hospital system in Milwaukee, the CEO, I believe in 2018, earned something like $12 million before, after bonuses, I'm not sure, but it's something in the tens of millions of dollars.
Yeah.
That's a huge harboring of money for a healthcare organization. Now imagine not having to report it. How much more money gets shifted and misappropriated within a system that's not held accountable through reporting? It's an astounding mishap in the tax code, and it's honestly it's advantage to Catholic hospitals.
Yeah, so you're saying basically that we have no way to monitor or track 70% of all the money in healthcare, or at least when it comes to money in hospitals.
More or less, yeah, and you take into account how much money gets shifted around through these systems. Again, it's a really complex, healthcare is a really complex system. Catholic hospitals nationally provide 1 in 6 of the acute care beds. That means you have a 1 in 6 chance of, if you need an acute care bed, like let's say you have significant symptoms from a positive COVID experience, there's a 1 in 6 chance that you're going to have to go to a bed in a Catholic hospital, and you're going to be under those directives.
That's if you're being airdropped to a completely random location in the United States.
And that's if you get airdropped to a completely random place in the United States. But some states are like a third of the beds in that state are dominated by the Catholic Church. And Alaska, which is a very specific place, I don't know how many of our members come from Alaska, but if you're here, hi.
Some.
50% of the hospital beds in Alaska are dominated by or are run by Catholic churches. 36% of hospital beds in Wisconsin are owned and run by Catholic churches. This isn't a small number. And it's larger than what the market share would otherwise suggest, even because those we're just talking about dollars. Here we're talking about healthcare provision. If you need that type of care, you have to go to a Catholic hospital. And honestly, it undoes a lot of people's rights.
Wow. Okay, so let's switch gears a little bit then and talk about what it means to actually be at a Catholic-run hospital, because some of our members might be sitting here thinking, okay, well, so the Catholic Church has this side project where they also run hospitals, and I get it. They're probably, they're in it to like do good in the world, so they say. All right, maybe our members aren't thinking this, but some people could be thinking this. What's the big deal that my local hospital is run through the Catholic Church?
Yeah, so that's a great question. I think it's to the point that really, this is what we're really trying to hammer in on this research. Catholic hospitals so let's back up and let's look at the work that we do. A lot of the work that FFRF does is to really examine separation of church and state. And unfortunately, we're in a space where legally the courts have said, oh, you're religious. We can't say anything about what you do because that's something religiously defined, right? One of the things that the Catholic Church does and the Catholic hospitals are required to abide by are these ethical and religious directives, these healthcare restrictions. And they're specifically written in the United States by the United States Conference of Catholic Bishops. There's 77 directives. They developed initially in response to Roe v. Wade, and they basically define and they spell out that if you want to be a Catholic church, if you want to be a Catholic hospital, you have to abide by Catholic principles, which means that in the space of healthcare, they will not provide abortions. They will not provide, when it comes to ethical care at the end of life, you cannot engage in assisted suicide. If there's any choice between the mother and the child, you have to preserve the life of the child, even if that causes the death of the mother. There are all these issues that keep coming up. And it gets more complex. So I have some examples if you'd like to hear them and talk about them.
Yeah, so I guess before we get to the examples, I just want to touch a little bit more on the directives. They come from the U.S. Conference of Catholic Bishops. Mm-hmm. They're incredibly detailed, and I know a little bit about them because I went through them for an amicus brief that we drafted a couple years ago for the Our Lady of Guadalupe, the Morrissey Beru case. It was a Supreme Court case which was not about healthcare at all, but about teachers at two private Catholic schools who argued that they were being discriminated against based on their age or health status, I think. If I remember, it was two different cases that were consolidated. Mm-hmm. But anyway, we argued that in our brief to the Supreme Court that if these schools were allowed to essentially fire these teachers under the theory that that they were basically that they were ministers, essentially. That was the school's argument for why they could fire these teachers, regardless of, things like their age, like that sort of those equal rights employment protections don't even factor in if we have this exception in the law for churches hiring and firing ministers of the gospel. And I'm getting too into the weeds on the Morrissey Barrow case, but basically
it's a frustrating case. So
it's an incredibly frustrating case because the Supreme Court ultimately decided, yes, if you are any employee at a religious school, and the school with a straight face can say, yeah, they're ministering to kids, in some sense they're teaching Catholic values to kids, then they count as a minister of the gospel. Then and we can hire and fire them at will, regardless of things like age discrimination. That's how the Supreme Court came down. And our brief was all about how, okay, that's scary enough at a Catholic-run school where, most people understand whether a school is a public school or a private religious school. But that same logic easily can transfer over to the healthcare field, and where people don't know necessarily if their hospital is Catholic-run. And most of the employees at Catholic hospitals are just, are doctors. They're not like Catholic doctors. They're just, like you said, with 1 in 6 beds in the country being controlled by the Catholic Church, you're going to have a lot of non-Catholics in doctor, nurse, support roles at all these institutions. And our brief was saying this is going to be a huge problem because the Supreme Court has basically greenlit the Catholic Church to control who can work at that huge share of hospitals in the entire country. And the reason why the Catholic Church can control that is because of these healthcare directives that from the U.S. Conference of Catholic Bishops. They're very specific about in laying out that healthcare is not just about treating the physical body of a patient, but also, to quote, Catholic healthcare extends to the spiritual nature of a person, and that pastoral care is an integral part of Catholic healthcare. They see doctors and nurses and arguably anyone else who works in the Catholic healthcare system as ministering. And there are specific duties put on all those employees to complement the role of a traditional pastor when it comes to the spiritual care of patients. And for that reason, I'm getting too much into employer-employee dynamics, and we're here to talk about patients' rights. So let's return our focus to that. So you have these healthcare directives, and they're broken down into sort of 6 different parts. So they talk about pastoral services, but then there's an entire section that has directives for professional patient relationships. They have an entire section that's about care for childbirth or care at the beginning of life,
Mm-hmm.
and another section for the end of life, right? Classic Catholic stuff. They don't really care what happens to you while you're alive, but they really care about unborn babies and then getting to minister to people on their deathbeds. But they also have an entire section that's about how Catholic hospitals can partner with outside organizations.
Yes.
Right? They put a lot of restrictions on that. So as you said, Catholic hospitals themselves aren't allowed to perform abortions or physician-assisted suicide, but they also are specifically directed that they can't engage in this is a quote, immediate material cooperation in actions that are intrinsically immoral in their eyes. And then they give those as examples: abortion and assisted suicide. So Catholic hospitals aren't allowed to partner with outside organizations that perform if their partnership will further those services in any way.
Yes, that's absolutely correct. I just want to take a sec. I'm going to return back to that, but I'm just want to take a second to respond to some of the chat, because you guys are chatting, and I'd like to say it. Yes, you're absolutely correct, Dan, that it was cholera, not tuberculosis. I misspoke. It was cholera. Dan Barker, always on top of it. Alan, yes, there's a very dark history that these early nurses there's a lot of coercion that went into it. There was a lot of abuse. Yes, there's a lot of former prostitutes or active prostitutes who are providing personal care to the soldiers. That goes into a whole other conversation about the history of women's rights and sex and sexuality within not only the church, but within the military. Is a whole other conversation, but a fascinating one nonetheless. And there is one more, Valerie. I only use the phrase assisted suicide because that is the language used in the directives, and it is a legally contentious one, particularly compared to what is a more appropriate term, medical aid in dying, which is one that is more contemporaneous. But unfortunately, there are some public health institutions that still use the phrase assisted suicide. I appreciate the recommendation and the language change, and I will adopt it if I continue to speak on that topic. Thank you. Okay, now
good comments. Back to sorry, we're very aware how framing like that is super important when it comes to public health.
Huge. And it's language that's shifting and changing all the times, particularly as we become less judgmental and more nuanced about what these things mean. And suicide is definitely one that is always complex to talk about, particularly with the connotations behind it. So the word choice is really, really important. So I will use the phrase medical aid in dying instead.
Okay, so returning back then to the Catholic health directives, I think probably I and a lot of the other people on this call would benefit from examples of like how in practice at the patient level this would be a problem.
Yeah. So okay, well let's look at some there. So as Sam, you said, the Catholic Church is very much interested, not necessarily in the lifespan of your healthcare, but in the beginning and the end of it, right? Making sure they have a large investment in abortion services, a large interest in how people end their life, or how life is ended.
Yeah.
We have specific directives around that. So we can look at I have some directives here if you want to look specifically at end of life care.
Yeah, but before you do that, I just realized my wife is in the healthcare field, and she'll wring my neck if I don't make this distinction. The Catholic Church is only interested in the beginning and end of a person's life. The actual physicians, nurses, and support staff who work at Catholic-run hospitals are very interested in patients' healthcare throughout their lives, and they're good people who, for the most part, as I said, are not even Catholic, but are just trying to do good work the way medical professionals do. All right, on to your examples.
That's a good point. That's a good point. And that is a great example of a healthy marriage too. As someone who's not married, I will take that bit of a exemplar and back pocket it for sure. um, yeah, okay, so end of life care, right? We're looking at the directives. Directive 60 specifically says Catholic healthcare institutions may never condone or participate in euthanasia or assisted suicide in any way. Dying patients who request euthanasia should receive loving care, psychological and spiritual support, and appropriate remedies for pain and other symptoms so that they can live with the dignity until the time of natural death. And Directive 24, we're gonna sandwich these and talk about them. Directive 24, the institution, however, will not honor an advance directive that is contrary to Catholic teaching. If the advance directive conflicts with Catholic teaching, an explanation should be provided as to why the directive cannot be honored. These are so specific sounding and yet so incredibly broad. And basically the large bar that we're seeing is if these things do not comport, if your advance directives with our legal contracts that help every healthcare consumer has a right to, does not comport with Catholic teaching, or if you request to go through the process of medical, or you request medical aid in dying, you will not be provided those things. They will not honor your contracts that you set out in your in your advance directives. They will not honor your healthcare requests and your right to seek medical aid in dying. They will deny you. And furthermore, they will not assist you in finding an alternative source, an alternative provider or hospital to help promote those things. So, and that's a huge HIPAA issue, and that's a huge issue in informed consent, that you will be misinformed if you go to a Catholic hospital where the directives are in contest.
You're saying that if I'm seeking, if one is seeking to go through with some sort of procedure that the Catholic Church personally frowns upon, and even if that patient doesn't know that they're at a hospital that's under the U.S. Conference of Catholic Bishops directives, they can be talking to their personal doctor, and the doctor is going to give them options, and like the actual best medical options might not be included in that conversation.
That is absolutely correct. This is the big asterisk here, is if the provider chooses to follow the ethical and religious directives set out by the United States Catholic bishops. If the provider does not comport with these directives, he or she puts the entire hospital at risk of losing their status as a Catholic hospital. So, and there are serious implications with that as well, which is why I use strong language such as "they will," because it's not foreseeable that any one individual provider will put the entire hospital at risk of losing their status. More likely, that provider will be terminated, and this comes back around to the employer-employee relationships that we were talking about, that really founds this ministerial exemption that we see in employment. Here, as a healthcare consumer, however, you put your trust in your doctor, you put your trust in your provider to say, this person has my best interest in mind. And in Catholic hospitals, that's just not the case. Not only will they not respect your, they will not grant or respect your wishes if they don't comport with these Catholic teachings, but they also won't inform you of otherwise medically appropriate care that you could receive at a secular hospital.
Wow. All right, yeah, that's awful. And okay, so do you have other sort of examples you want to go through of ways that this could impact patients?
Yeah, sure. So I recognize that we're at 10:43 here. I'll give you the option. Okay, how about that? So I have an international example in Ireland. I have a couple examples in reproductive care, and I have an example in vaccines.
Yeah, I think let's do the reproductive care one, because I know that I'm seeing a couple comments about that.
Okay. All right. So here are two examples, and I really want us to focus on because this could have been any of us. So the question is, how did that person get in that situation? How did they get in that predicament? What can they do? And how can you prevent yourself from being in this situation in the future? So here's example number one. Mindy Swank from Illinois was denied an abortion at 20 weeks by 2 hospitals because there is a fetal heartbeat. She suffered from severe bleeding, hemorrhaging, emotional distress, and risk of infection for 7 weeks until labor was finally induced at 27 weeks. The baby died shortly after delivery, and she was never informed that she could go elsewhere for services. So both of these are examples provided by the ACLU. Both of these are real examples that happened. Another example, at 7 weeks, Maria, and her name has been redacted by the ACLU for protection purposes, from Washington, began experiencing heavy vaginal bleeding and knew she was miscarrying. She was a nurse, so she had advanced medical knowledge that she was miscarrying. Even though she knew the hospital had ERDs, these ethical and religious directive restrictions, her insurance would only cover services at that hospital. She couldn't afford to go to another hospital to pay out of pocket. So the hospital waited 7 hours until she finally needed a blood transfusion due to the loss of blood, which increased her risk of sudden fetal demise for her future pregnancies. And so the question is, where your healthcare is denied. It's an unfortunate truth that miscarriages are very common. They should be destigmatized. They're very common, they should be destigmatized. And if you go to a Catholic hospital, which you could just end up there like Mindy or Maria, for reasons outside of your control, they will not assist you in that miscarriage if they identify a fetal heartbeat, unless you are essentially on your deathbed, and you shouldn't have to get to that point.
Wow, that was incredibly informative. Thank you so much for participating in Coffee and Conversation, and I'm sure that's sparked a lot of questions from our viewers today, and I know that they were very engaged while we were doing it live back last month. So let's see what kind of questions we've got here. Oh, unfortunately, I don't have names associated, so whoever's been engaged in asking questions, thank you. Let's start with the first one. So, other than obvious things like access to abortion, what other issues exist in Catholic hospitals? Is there documentation of disparities based on patients' religion, sexual orientation, race, etc., regarding treatments, access, and outcomes of procedures?
That is a great question. It is one that comes up frequently because as we try to understand some of the disparities that happen between religiously affiliated and secular patients, it's difficult to track sometimes because of HIPAA issues that we were talking about prior to the show going live again. But to answer the question pretty generally, yes, there are other issues that arise outside of before life and in death matters, right? So these ethical and religious directives developed after Roe v. Wade, in response to Roe v. Wade. But we see that the Catholic directives are much more invasive than just that. So take, for instance, whether or not you want to see a chaplain, right? There are many individuals who will at some point say, I am religious, I'm a religious person. They'll put it on their hospital information, and then at some point in their life they say, you know what, I'm not a religious person anymore. Let's say they are Methodist. Someone from the Methodist church could come to the hospital and say, I want to see all the Methodist, like a chaplain could come to the hospital and say, I want to see all the Methodist patients here. And that chaplain will have access because your religious identification is not protected under HIPAA from chaplains because it's how they get access to those patients. And that's certainly outside of the scope of those who are seeking assistance in the end of life and those seeking assistance in, say, abortion care. So there are a lot of issues that come up. I think moving forward academically, it'll be important to gain access to that information, those health records, and really disseminate and separate how people are identifying, whether they identify religiously or non-religiously, and what circumstances and settings they're receiving care. So I think there's a pathway forward to understand it better, but that's where we're at.
Okay, well, fair enough. And let's see here. So another viewer asks or states, I've heard stories about same-sex couples being denied visitation rights in Catholic hospitals, even if they're legally married. Is that legal?
Is it legal? So this is a tricky one, certainly. So let me start by saying, while these are the Catholic ethical and religious directives we're talking about, that is a very systemic and nebulous thing. Each individual provider may make different choices that are contrary to that. Now, I can't assume that they're going to make contrary decisions to that, but they certainly could, right? And we see that happen. But in terms of visitation, one's status as a member of the LGBTQIA+ community is related to the principles of Catholicism, depending on how it's interpreted, and that could be a bar for visitation. The issue here, more so than just the specific issue of visitation, is the fact that patients' rights that are otherwise protected in common law and protected in federal statutes do not govern and may not govern Catholic hospitals, right? You can go into a space seeking care and lose constitutional rights, lose federal rights that are written down in black and white. You can lose access to those rights because the court refuses to regulate these institutions and these directives. And that's a major issue. That's a huge issue, and it's an undoing of justice, in my opinion.
So is this a riffra situation, basically? Does this derive from that?
It could be a riffra situation. The problem is that it's really gone untested. And so whether or not a hospital or an entity tries to incite riffra, it's untested. And we don't have administrative guidance on the application either, because these issues get skirted all the time. The test hasn't come up yet.
Sure. So this is something that would have to work its way all the way through the courts to have a better answer.
It would. Yeah.
Wow.
But I'm thinking that because of COVID, because of this period in time, and how the court has treated, that the shadow docket has, or the shadow court has treated some of these COVID cases, particularly with something like visitation, we're going to see some hospitals become more brazen, right? And it's going to force the court to take on the question. So I think that we're going to see this coming up pretty soon.
Well, we'll keep everybody posted. Let's see. We've got another question. I think this comes very close, follows nicely. So are there any practical tools that people can use to limit the imposition of religion on you when you're in a Catholic hospital, if that can't be avoided?
Yes, there are very practical tools. The first is stay out of Catholic hospitals. That's got to be the first one.
No-brainer.
It's probably the most difficult to do, though, right? Yeah. As I was saying in the coffee and conversation, you can end up in a Catholic hospital just by function of where you live, where your zip code is. Some zip codes only have Catholic hospitals serving them, and so if they get into an emergency situation, they're going to be sent to that Catholic hospital. Some insurance providers will only cover, in your HMO area, they will only cover the Catholic hospital that's in your area, right? And it makes it really difficult to.
Well, I think we found a graphic related directly to this. So this is a graph of Catholic hospital market share in U.S. counties. And
yes.
It looks like the red is where Catholic providers are dominant, and that's a fairly large portion of the country. And if you live in those areas, not only do they look like they're rural, so you're going to have to travel to get out of that, but here we are, and they're growing apparently. Yeah.
So in the last graphic, that was a graphic of market share. So when we're talking about market share, we're really talking about dollars, right? Okay. And you can see in some of those red ones, 70% of, 7 out of every $10 spent, 70 cents on every dollar goes through a Catholic hospital, which is
substantial
amount of money when you're talking about, reimbursements. You're talking about the state's offset of bad debt. You're talking about federal subsidies. All of those are going through Catholic hospitals, and they don't have to report them the same way as secular hospitals. So you don't actually know where that money's going.
What? They have different financial reporting requirements.
They have different financial reporting requirements. Yeah.
That seems pretty unfair.
It's pretty baffling. Now that some of these hospitals still file 990s, right? But they're considered 501c4s, not 501c3s. And because they have the religious and social being entity, they don't have to report as many things either, right? So what any individual makes, they often don't report that.
Wow. Well, and that's something that FFRF has been tackling, since its inception, essentially, the disparate treatment between, nonprofits like FFRF and nonprofits that are churches. And it's vast and shocking.
Yeah, it is.
Wow. So let's see here. Are there any potential legal solutions that could be brought to protect people's rights from the imposition of their religious healthcare providers?
There are some legal solutions, and I'm actually going to tie this to the last question as well, because for someone seeking more practical answers or more practical ways to navigate the healthcare system, like I said, you can try to avoid these hospitals with ethical and religious directives by simply calling and asking, hey, are you operating under the Catholic ethical and religious directives? Finding out what information, avoiding it as best you can. But if you do find yourself in a situation, speaking with the nurses and hoping that someone will take a more human approach as opposed to a religious approach to your healthcare, I think is important, because you still have a chance to say, hey, I don't want a chaplain in here, or can you take these symbols off the wall or something. They might listen. It's no guarantee. Now, legally, it's a little bit of a different conversation. We need a case to come up that will test that will force the court to really draw a line, and that's what we're seeing with, or we're getting some guidance that the court is really reluctant to do that. Right? If a individual comes into the hospital during a pandemic and has COVID and tests positive and is at risk of infecting other patients, do they still have a right to see a chaplain who otherwise doesn't have COVID, who otherwise could get COVID and could spread it, right? Is there a limit and a bar to those rights? I think that there should be. The court has entertained it, but has not decided concretely with specific opinion and guidance on what they're willing to do and say about that.
Sure. So this is a situation where secular individuals really need to be informed and take the opportunity to advocate for themselves and push to avoid those things and kind of see what shakes out. Basically, is what I'm hearing. Yeah,
it's like a religious dare program. Just say no. You just gotta avoid it.
Well, and again, that's why organizations like FFRF are here. We are here to gather secular individuals in one place, give the information, share the power, build the power. And that's why, this program, Coffee and Conversation, is available only to our members live, so you can interact and ask those questions directly. But then, of course, we're very giving and sharing individuals, so we make it available on Facebook Live occasionally. Can't make any promises in the future. So, well, that is all the time we have for today's Ask an Atheist. Again, we invite everyone who's watching, if you're not already a member, to go to our website, ffrf.org, and join. Thank you so much for being here. Thank you so much, Joseph, for educating us and joining us. And we look forward to seeing you all in a couple of weeks when FFRF Ask an Atheist is back live again.